I'm very honored to be here with you to this National Congress of Physical Medicine, Rehabilitation and Balneoclimatology in Covasna. I regret so much I'm in Ljubljana to SHA Preventive Cardiology, and thank you so much for this opportunity. In the next minutes, I shall present a complex approach to the recovery of patients with peripheral arteriopathy using the potential of the natural factors of Covasna resort. Nothing to declare. Peripheral arterial diseases are highly prevalent and significantly increase cardiovascular mortality and morbidity in the general population. Intensive preventive strategies are needed. Patients with PET are generally underdiagnosed and undertreated compared with patients with coronary artery diseases. In patients with PED and CAD, often common risk factors coexist. For effective management is necessary a multidisciplinary team. The early diagnosis is very important for better outcomes. New guidelines offer guidance on diagnosis, surveillance, and treatment. The last and the newest guidelines of European Society of Cardiology are from 2024. Prevalence of rate of PAD, peripheral artery disease, from age of 40 is rising with the age and is more frequently in female than in male. This shows the statistics, and it is important to have a look on this pathology. Cardiovascular risk in peripheral artery disease is 4-5 times increase of risk for severe events compared with patients without PAD. So cardiac disease, MACE, CV mortality, myocardial infarction, coronary revascularization, hospitalization for heart failure is higher in this category of patients. Also, cerebrovascular diseases are more frequently. Lower limb disease, male, amputation, chronic or acute lower limb ischemia, lower limb revascularization, which give increased death and vascular amputation risk is higher in these patients. So, central therapeutic aims are to reduce the risk of MACE, to reduce the risk of male, to improve quality of life. The guidelines told us that when we are managing PAD, it's recommended to adopt a comprehensive approach that addresses the entirety of arterial circulation. From diagnosis to treatment, a holistic multidisciplinary peripheral arterial and aortic diseases approach is needed. So, from prevention, diagnostic, treatment, and follow-up, we need a multidisciplinary team with great attention of its elements. How to know when a patient has a PED? For screening for peripheral arterial disease, it's a very simple method, ankle brachial index, ABI, or two brachial index, TBI, when it's not possible, the first one. These are hemodynamic criteria for PED. The guidelines like recommendation class 1B, told us that measurement of the ABI is recommended as first-line non-invasive test for screening and diagnosis of PET using an ABI less or equal 0.90 as a diagnostic criterion. In the case of non-compressible ankle arteries or ABI more than 1.40, additional methods such as TP or TBI or Doppler waveform analysis are recommended. What is important to know for atherosclerotic PED is that we have common risk factors in peripheral artery disease and coronary artery disease. These are traditional risk factors, non-traditional risk factors, non-modifiable risk factors, modifiable risk factors. And for female, we have specific risk factors. For treatment, for optimal medical treatment, we have to address general severe risk prevention and address lower limb-related symptoms, improve quality of life. So the optimal treatment in patients with peripheral artery disease address to smoking cessation, healthy diet, weight loss, supervised exercise training, and also to antihypertensive drugs, cholesterol-lowering drugs, optimal glucose control in diabetes, antithrombotic drugs. What is new? New recommendations for antithrombotic treatment. Recommendation class 1A, use of antiplatelet therapy with aspirin alone, 75 to 160, or clopidogrel alone, 75 milligram, is recommended for the reduction of MACE in patients with symptomatic PED. Treatment with combination rivaroxaban and aspirin should be considered for patients with PED, high ischemic risk, and non-high bleeding risk. Recommendation for antithrombotic treatment following revascularization. What is new? Treatment with combination rivaroxaban and aspirin should be considered for patients with PED and non-high bleeding risk following lower limb revascularization. Dual therapy for at least 1 month after revascularization may be considered to reduce limb events. Regarding antihypertensive therapy, are new recommendations in patients with PED. In patients with PED and hypertension, systolic blood pressure target towards 120 to 129 millimeter mercury, if tolerated, is recommended. Class 1 level A. In patients with PED and hypertension, inhibitor of ACA and or triptan should be considered as first-line antihypertensive therapy. In persons more than 85 years in residential care, symptomatic or orthostatic hypotension, goal for blood pressure is less 140 per 90 millimeter mercury is to be considered. Regarding lipid-lowering therapy, new recommendations class 1A, in patients with atherosclerotic PED, lipid-lowering therapy is recommended. An ultimate LDL cholesterol goal of less 1.4 millimole per liter or 55 milligram per deciliter, and more 50% reduction in LDL cholesterol versus baseline are recommended in patients with atherosclerotic PED. Statins are recommended in all patients with PED. If the target LDL cholesterol level is not achieved on maximally tolerated statins and ezetimibe, treatment with PCSK9 inhibitor is recommended in patients with atherosclerotic PED to achieve target values. If the target of LDL cholesterol level is not achieved, a combination of statins and ezetimibe is indicated in patients with atherosclerotic PED to achieve the given target values. For statins intolerant patients with atherosclerotic PED and at high risk cardiovascular who do not achieve the LDL cholesterol goal on ezetimibe, it is recommended to add bempedoic acid either alone or in combination with PCSK9 inhibitors. Very important and very useful in treatment of patients with PED is exercise training. Exercise training in PED could be supervised hospital-based exercise program or supervised home-based exercise program at least 3 times per week, session duration at least 30 minutes, program duration at least 12 weeks. Benefits of the training: less symptom, better quality of life, better working performance, better patient awareness, and better functional status. Mechanisms involved: improvement of mitochondrial function, arteriogenesis, endothelial function improved, rising of myofibril size, less inflammation. New recommendation of exercise training in PED, recommendation class 1A are in patients with symptomatic PED, SET is recommended. In those patients undergoing endovascular revascularization, SET is recommended as an adjuvant therapy. When SET is not available or feasible, a structured and monitored HBED program should be considered. Training frequency at least 3 times per week, duration at least 30 minutes, and the training program duration at least 12 weeks should be considered. Recommendation about follow-up in PED but guidelines. In patients with symptomatic PED after 3 months of period of OMT and exercise therapy, PED-related quality of life assessment is recommended. Class 1B. In patients with symptomatic PED and impaired PED-related quality of life after 3 months period of OMT and exercise therapy, revascularization may be considered. It is recommended to regularly, at least once a year, follow up patients with PED, assessing clinical and functional status, medication adherence, limb symptoms, and factor risk cardiovascular control with DAS assessment as needed. Highlights from guidelines: multidisciplinary approach and multimodal treatment strategies, decision-making with vascular team involvement, implementation of exercise training in symptomatic, effort-related PED, follow-up strategies, and recognition of patients' quality of life. Goal: for us, promote independence, improvement of quality of life, and prevention of further deterioration of cardiovascular health. Supervised exercise therapy, set first line of treatment, strongest evidence, multiple meta-analysis, and the guidelines recommend structured working programs as first line therapy for patients with intermittent claudication. Effectiveness set significantly increases both pain-free and maximum working distance up to 150% improvement within 3 to 6 months. Recommended protocol at least 3 sessions per week, 30-60 minutes per session under supervision. Alternative exercise approaches, arm and cycle ergometry, strength training. Guidelines are mentioned as for recommendation class 1A. In patients with symptomatic PED, SET is recommended. In those patients undergoing endovascular revascularization, SET is recommended as an adjuvant therapy. About health insurance perspective, limited reimbursement are mentioned in guidelines. So, in patients with symptomatic PED and impaired PED-related quality of life after 3 months of period of medical treatment optim and exercise therapy, revascularization may be considered. It's important to change lifestyle. So smoking cessation and lifestyle modification, strong evidence smoking cessation is the most impactful modifiable risk factor, significantly reducing cardiovascular events. Diet and weight control, antithrombotic therapy are very important. We need pharmacological support for rehabilitation. So statins lower cardiovascular risk and may improve working ability. Recommendation of class 1A, like I talked before. So it's important to control and to have pharmacological support for blood pressure control. In conclusion, a SET or HBET, gold standard for conservative PET rehabilitation, comprehensive medical and non-medical management crucial to improve outcomes, mitigate symptoms and reduce the risk of MACE-mail. Pharmacological secondary prevention supports rehabilitation but cannot replace lifelong and high levels of regular physical activity. Revascularization is required for treatment-resistant cases or critical ischemia. What is something unique in Europe and in our country is Covasna model, where in which non-pharmacological treatment well known and pharmacotherapy are completed by the natural factors of Covasna, climatotherapy, aerotherapy, baths with mineral waters, with CO2, and Mofette's dry bath with CO2. Covasna has a moderate climate of medium-height mountains with sedative effects, altitude about 600 meters, rich negative air ionizations, resinous aerosols from the coniferous forests. The carbogaseous water have best effect when concentration is in CO2 is about 1 gram per liter. They bring cutaneous peripheral vasodilating effects. The values of blood pressure are decreasing. we obtain through baths CO2 with mineral waters, reducing of peripheral resistance and increase the systolic flow, results of cutaneous vasodilation. It's obtained an economical moderate training of the heart. It is like an exercise of adaptation of the systems of neurovegetative and endocrine regulation. It's increasing the venous return flow with the better vascularizing the heart along with concomitant reduction of the pulse frequency due to the induced hypothermia are all favorable effects on the carbogaseous bath with various cardiovascular patients. The baths are at 32, 33 degrees for 20 minutes. This procedure is better described by my colleagues and their presentations. Mofetes, there are dry baths with CO2. CO2 is the main element of the emanations of gas of Mofeta from the volcanic regions. It is applied in special rooms where the gas is accumulation in the decline of the room, being heavier than the air. We have also some other elements, sulfurous and radon emanation. This is the room of Mofeta, where patients have at foot a concentration of 19% of CO2 and 1.2 to 2% CO2 at the level of nose. It is a schema of action of CO2 at inhalation, cutaneous effect, and respiratory level. So bringing vasodilating effects following the inhalation, the Mofete of an air containing a high percentage of CO2. The cerebral and muscular circulatory flow increases, which accounts for favorable effects of the Mofetes in the atherosclerosis with arterial, peripheral, and cerebral localization. The model Covasna is applied for 66 years in Hospital for Cardiovascular Diseases, Benedegeza, Covasna, where we have referring to peripheral arterial disease, exercise programs in group or individual, and they are applied supervised after evaluation of the patient. Look, all kind of exercises here. They are important and we have very good results. In addition, we could recommend electrotherapy, which can be used in treatment of PET to improve blood circulation, reduce pain, and aid the healing of lesions, stents, currents, and galvanic currents. We have to take in consideration the role of telemedicine in PED, very important, and the role of AI in PED to improve the quality of our work. In conclusions, patients with PED should receive comprehensive medical optimal treatment, including supervised exercise training and lifestyle modification, a personalized program of guidelines-guided pharmacotherapy to reduce cardiovascular risk factors, major adverse cardiac event, major adverse limb event should be prescribed and entirely followed. The program with carbogaseous waters and mofetes added to classical program to patients with PAD, improve peripheral circulation and normalize vascular hyperactivity, improve collateral circulation and claudication index, reduce tensional values, and give bradycardic tendency during cures. Programs for recovery of patients with PAD could be improved, use the potential of the natural factors of Covasna resort. So it's very important, Covasna for treatment for rehabilitation of patients with PAD and other cardiovascular diseases. Thank you so much. Felix?